Good morning, and you're very welcome to this INTERDEM symposium. My name is Esme Moniz-Cook, and I'm one of the INTERDEM board members. And this particular symposium is part of one of our task forces work. We've got plenty of task forces, and I would urge those of you who don't know about INTERDEM to go on our website, interdem.org, and have a look. And anybody who wants to join INTERDEM with the there's ways of joining, please do go on the website and put in an application if you're eligible. So this has me done my pitch. So social health has been something that Myrra Vernooij, who was the first speaker, first conceived and adapted for dementia care in about 2014. And today is part of the ongoing developments about social health. With INTERDEM, there's always extra work. You do something and you discover more work to be done. Now today is much more a concentration on what social connectedness is all about. And the first talk by Myrra Vernooij, who was our previous chair of INTERDEM, will take the floor for the first talk now. Just to say, we are hybrid, so people need to download an app to participate in the question and answers and polls for the hybrid sessions. And there is a seated lunch at the end of this symposium. I think you might have to check. Apologies. I've just been given a list to remind people. What we're going to do is, if there's time for questions after the first talk, each one has 15 minutes. We'll take at least one. But my plan is for you to write down any questions just in case, and we have 15 minutes, so just under at the end. Thank you.
Thank you, Esme. Can you start the presentation? Yeah, thank you so much. Welcome here, and I'm happy to talk with you about stigma and social health, and I'm also happy to discuss about it. Stigma is a very old concept which is very well known and addressed for many years, but in essence it defines a person to a deviant characteristic. A person is nothing more than, for instance, a person with dementia. And by doing that, it deprives the person from obligations, rights, and participation. Well, depriving from obligations, that might seem a relief, but it's not. It's important that people are considered as full, capable persons, and then you do have obligations. I will expand much more on the rights and participation. That's a key thing in social health. And stigma is, in fact, a major challenge to social health. This is something you really have to deal with in case of dementia. It causes social exclusion, and people not only are excluded by others, but what we learned from qualitative research, that they also exclude themselves, and that they say, I don't have need to meet other people. And what is the worst of all is self-stigma, that the person is going to believe that he is nothing more than the stigma. And stigma is not just a single thing, it has many, many faces. And I would like here to concentrate on the triple societal stigma of dementia. The triple stigma is, you can recognize it on a societal level, and it has been done, it is done, well, not on purpose, but it might be a side effect of things which are meant to be good. For instance, for fundraising, making the case of dementia by emphasizing the deficits and by emphasizing the end stage of dementia. And also, it's meant to do good for people with dementia. It is really doing harm to the population. I will come back to this. And another thing is, and it's in fact spoiling the strategy of an organization who really wants to do things for people with dementia, and they are being engaged in it and doing many things very well, but they often spoil it by this kind of campaigns, which is another thing of people with dementia. It's well, in most cases, a disease of older people, and older people are confronted with ageism in society, is discrimination based on age. And the third thing I want to emphasize, well, speaking about social health, is loneliness. In the States, it's already called an epidemic, and it's compared with the negative effect of smoking 15 cigarettes a day. And for instance, in Sweden, there is a minister of loneliness, and loneliness is in all ages, and the data show that it's not particular in older age. It's especially young people are confronted with loneliness. What I want to show this slide because it gives a very good impression of the consequences of frightening people. And the communication in the media is very frightening on dementia. So I translated it. If I would get dementia, these two young kids, I might want euthanasia. Suffering lonely in an understaffed nursing home, I would rather die. And this is not a joke. This is very serious because people are confronted with the last stage of dementia, and only 14% of people living in a nursing home reach that stage. So in the total dementia population, it's much less. So they are frightened for things that might not come. And what they can do is ignored by stigma. So it's really, really serious. And we try to overcome this and to address this by the concept of social health. Sorry. And social health is essentially a relational concept. So it goes beyond other health aspects, the physical and the mental. It's not only connected to one person, but also to others. And it's defined on the impact that an individual has on others. So the individual can really influence his or her own social health, and the impact that the social environment has in turn on the individual. So this is a key concept, and this also means that you can influence your health, and you can also influence the stigma, at least stigmatizing yourself. The research findings so far indicate an array of modifiable risk and protective factors. And, well, how did we find that? We started with defining what social health was and with defining domains of social health. Here they are. And I was talking about depriving from obligations. Here, having obligations is very important for the health of a person, and focusing on capacities as well. Then, on the personal level, autonomy is very important, and social participation. And the thing is, it's a relational concept. So on the one hand, the person, on the other hand, the environment. And the base for the environment is a social network. and then social functioning, including social support, and the appraisal of support. And that can differ hugely from the objective support. And loneliness is an appraisal. And I will say a little bit more on social health. Here is the full picture of social health on the two levels. And what in the last row you see some of markers. So if we look at stigma, then with regard to capacities, you can fight stigma by allowing persons to use capacities and to stimulate persons to comply with social norms. Which is crucial is respect autonomy and stimulating social participation. When we look at the social network, maintenance of the social network is really important, and you can do it all your life. You can build it and you can maintain it, and you can keep building all your life. Well, like being here, you get new relationship and you really cherish the one you have. And that's why these conferences are such a great thing, and do many of us really join. Then with regard to social functioning, exchange of support is very important. And people with dementia, they really like to be involved in decisions. And often they don't want to make the decision, but being ignored in important decisions, and important decisions are decisions in daily life, usually very simple things. And then the reduction of loneliness. Well, what is crucial is that social health can play a great role in destigmatization. It can even be a kind of antidote. When you keep people with and without dementia included, then you really make a strong statement against stigma. And I will come back to that later. What we found in a qualitative study is unease addressing unease is a very important thing. And with regard to what we already learned also from Mia Kivipelto, that social activities and activities, for instance, exercise, which you do in a group, these are very important social health activities. And eating together, for instance, is one of the initiatives that can be taken. Well, what we really want in social health research and in INTERDEM research, that we have a closer idea of mechanisms. And we try to get better informed by the people with dementia themselves. And we studied in a qualitative study the interaction in people with dementia with their social environment. And a key finding in this interaction was unease. Well, we were rather surprised to find this. We expected many problems, but this one was the most prominent one. And in this qualitative exploration, both the caregiver was involved, the person with dementia, and the professional. And looking at unease may be a way to destigmatize. The thing is that if people have problems or avoid people with dementia, when you are aware that it's unease, then you can deal with it. And so this publication will come really soon. And a way to address unease is you can do it in very many ways. You can do it with words, but you can also do it without words. And what I want to share with you, what struck me in the opening of the academic year at my university in Nijmegen, that we had a poet in residence. And the poet made a poem on loneliness. And I want to share this with you. It's about consolidation, and it's about a way to make contact. Just to see you walking there, on the way from one place to the other, with your eyes knocked down, no, smashed to pieces on the pavement. Oh, if only loneliness was a rarity, I would not have recognized her so quickly. But if you would only look at me, I would greet you, show you that you are not alone. And I will greet you with a smile that will, even more than 1,000 words or 10,000 poems, that will, as being 100 violins, engrave the consolidation in your heart, that we are whole in the smile of the other. Thank you for your attention.
Thank you, Myrra, for starting off this exciting symposium. I think I knew your work really well, and here am I making notes. I've written 3 things down to pick up sometime in the future. I think what we'll do is we'll hold, and just for those people who are hybrid, keep your questions, and we'll come back to it, because we might want to put some of these ideas together at the end. So I'd quite like to now ask Dorota from Poland to take the floor. And Dorota is part of the shared JPND project across Europe, which has just completed another INTERDEM-led study. And you're very welcome. It's the first time I'll be hearing your work from Poland. So thank you.
Yes, thank you for having me here. It's really nice to hear all the work that's been going on. So yeah, I'm a second-year PhD student at the University of Nottingham, based in the UK. Primary supervisor is Martin Orrell. No pressure, because he's in the room right now. And I'm going to be talking about one of the ongoing studies that's going to form part of my PhD. And just before we start, I do want to say thank you to the public health interns, Yinyu, Justin and Selena, who did a massive amount of work on this project for us. Okay. So over the last few decades, there has been an increasing concern over human rights in dementia care, and it's become a significant concern since the adoption of the United Nations CRPD, or Convention on the Rights of Persons with Disabilities. So just to give a quick overview, the aim of the CRPD is to promote, protect and ensure equal and full enjoyment of rights and freedoms for all people with disabilities. This includes people with dementia, undoubtedly, really. And the CRPD has actually been ratified by over 180 countries worldwide. Following on from this, the World Health Organization and Alzheimer's Disease International declared dementia was a public health priority, not least because of the global extension in population, but also the increasing life expectancy. Then in 2017, the WHO adopted their Global Action Plan on the public health response to dementia, setting targets between 2017 and 2025. One of these targets was for 75% of countries, member states, to have a national dementia plan either updated or newly developed. And the Global Action Plan emphasises a rights-based approach, which means that countries should be aligning their plans with the CRPD principles. However, the progress on this was slow, so the Alzheimer's Disease International launched their What's Your Plan campaign in 2021. We know that everyone's favourite P-word, pandemic, did not help with this, but at the moment, the current target is unachievable. So there have been a couple of reviews of national dementia plans, but in terms of whether the CRPD was reflected within plans, Alzheimer's Disease International and Dementia Alliance International, International, found that the CRPD was not actually reflected in several plans. But this was before the Global Action Plan became adopted by several countries. So we decided that we wanted to examine the rights content within these plans and including references to the CRPD. So to do this, we have been looking at using a deductive content analysis because we know that it's good with very large text-based data. So I created a template using specific CRPD principles and rights synonyms such as autonomy, dignity, and empowerment. We then downloaded plans from ADI, Alzheimer Europe, and WHO Mindbank database, as well as scoping Google, just in case we missed any. So initially, myself and the interns piloted the same 3 plans just to ensure reliability and validity of the template that we were using. We then searched the plans using the find function for PDF, so Control F, using these keywords, and any synonyms that we could think of, just in case we missed it. So if you read the abstract, it did say that we were hoping the analysis would be done by the end of July. Unfortunately not the case, because midway through July, we then got access to 16 additional plans through translation, thanks to the ADI. So all plans have been examined now, and they've been done by at least 2 people. So overall, we've looked at 46 plans, with the majority from the European WHO region. 3 were from countries that are not part of a WHO region at the moment, and none were from Africa, which matches the ADI progress report. So we have been unable to access 9 of these plans. By unable to access, I mean these are countries that have plans, but we haven't been able to find them. And we've also been unable to translate 2 of them due to technological difficulties, which I am working on very slowly at the moment. Most of these plans do also come from high-income countries. So all of these plans were launched after the CRPD was adopted in 2006 and range from 2010 to this year, which is fantastic. However, of these, only 28% of the plans actually mention the CRPD specifically. There were 23 plans created after 2017, so when the Global Action Plan was adopted, and it's only mentioned in 12 of them. 2 of them do mention the draft from 2016. So I don't have a specific number, but the majority of the plans do state that people with lived experience of dementia were involved in the creation of these plans. So by people with lived experience, we mean people with dementia, care partners, support networks, and family members. And overall, legal capacity and community inclusion, including social connectedness, were the most mentioned rights. So we decided to group our findings into the rights aspects that the WHO do for their Quality Rights Initiative. So the first one is respect for legal capacity, which is guaranteed by Article 12, equal recognition before the law of the CRPD. So legal capacity is the right to make decisions and have those decisions respected, and countries should also be supporting people to make their decisions. It was mentioned by just over 91% of the 46 plans that we looked at, which is pretty good going. Many of these plans actually do specify supported decision-making and advanced care directives. Second one was alternatives to coercion, which is covered by several CRPD principles, but the one we've chosen is Article 16, freedom from exploitation, violence and abuse. However, only 63% of plans make any sort of reference to alternatives to coercion. So alternatives to coercion would be practices that meet the wishes of people with dementia and that do not include involuntary admission and treatment, restraints or seclusion. Participation was the next one, and it's covered by Article 29 of the CRPD, participation in political and public life, which means being able to vote and be elected, and also participate in the design and delivery of the services that support them. About, I can't quite read that, 87% mention participation in any shape or form. And then finally, community inclusion, which is covered mostly by Article 19, living independently and community inclusion. This was the most mentioned right, and it basically means anyone can live within the same community, choose who they live with, access the same community services as others as well. And it's covered by just under 96% of plans. So while all of these overlap, it is important to know that person-centred care we wanted to look at specifically as well to see whether these plans do mention person-centred care, or at least a synonym of it. And this is the care that meets the needs and wishes of people with dementia. And 89% of these plans do specifically mention person-centred care. So the key here, the pink text is where it's contextualised information, and green is an actual action point. So to give some of the evidence for you, Malta from 2015 described the importance of advanced care directives because it maintains the autonomy of the person with dementia and means that they can be involved within their decisions that affect them. So the action point for this was then to work towards the development of advanced care directives. Now, although alternatives to coercion was rarely mentioned compared to the other rights, Spain, for example, had an action point to develop information actions, training and protocols, which was aimed at minimising involuntary restraints, both physical and psychological, pharmacological as well, within the care environments, including the person's own home. So for community inclusion, Cuba stated that they would incorporate the elderly with dementia into social, recreational and cultural activities within the community. Note that they say elderly. We are not quite sure whether they want to include people with young onset dementia in there, so it's something that we need to double check, but it could be something that they need to work on further. And Austria described that people with dementia should be able to participate in community life by improving community support, but don't necessarily give an action for that. And in terms of person-centred care, Australia from 2015, we know has a plan coming out soon. It says that they will provide people with dementia, their carers and families access to person-centred care support in order for people to have access to quality dementia care and support. Okay, so just to go over a quick conclusion, the results are still ongoing. We're still working very hard on it. But the plans so far show that they're good in acknowledging the basic WHO and CRPD principles, with community inclusion and social connectedness strongly covered. However, further work is needed regarding coercive practices, and also just maintaining the point that people with dementia do have equal rights as, to others. Some plans mention rights in passing, so they contextualise the issues very well, but then don't necessarily action on those contextualised issues. And others, such as Austria, do have recommendations for action. So with the new plans, and with it being unfortunately just me at the moment, we're hoping to complete analysis by the end of November this year. As I stated, we do have inaccessible plans that we know that we've missed, and we will be looking for these every 2 weeks. More plans are being launched in the future as well. So like I say, Australia just released a final draft and presented it to people. So we are expecting their plan to come probably towards the end of the year, maybe in early next year. We will be making further attempts at the translation for the 2 that we've been unable to translate so far, because we want to encompass as many plans as possible within our study. And one thing that we do know is that the ADI called for an extension to the Global Action Plan's deadline of 75% of member states. This was, rather than 2025, was to 2029 instead. And we hope that the results of our study can inform the ADI, Alzheimer Europe, and the WHO as to how plans can be more rights-focused. So just a very quick overview of the main references that I've used today. And I'll end on this slide. The QR code has exactly the same information, it just saves it to your phone a bit better than a photo sometimes. But yeah, I'll leave them up there just in case anyone wants to get in contact and follow up. Thank you.
Thank you, Briony. And I'm delighted to see that we've got even more time for a hopefully lively discussion, question time. And I see that we've got some people online. So if anybody online wants to ask a question, please ask it on this iPad, and I will attempt, in my very poor technology, to read it out. But let's start with just a quick summary. I was quite interested in the theme that came out initially with the whole moderating fact of actually feeling lonely from Myrra's talk, but also the lovely overarching diagram that you presented to us, which can incorporate so much and also show us the gaps. And with the thing I drew out of Dorota's talk particularly was, you know, we all quote this Lancet and the Lancet again, and here you have in depth started up looking at more social outcome or predictors or risk factors or markers, whatever you want to call it. I'm hoping that this will stimulate from your talk very quickly some new cohort studies that will add to some of these other things that you've identified. And if they are, please, will people contact me? I will join, because if I live for another 20 years, I might actually contribute to some data collection somewhere across the world. And picking up on Georgina's theme, it was particularly interested again to look at how the notion of younger people and older people have different appraisals and can help or hinder interventions due to the way they think. And it brought to me Myrra's earlier point that we really need to involve a lot of people, across, whether they've got dementia or not, as well as younger people, to begin to start understanding how in middle age we can address the stigma and fear. And finally, Briony, all I can say is that I'm highly impressed at how much you've achieved despite pandemic. And again, in Myrra's model, you could begin to see how at policy level we can begin to start ensuring that at least the plans have information. I was particularly interested in the bit that Spain has, which is coercive, pharmacological, relating to my own kind of BPSD or behavioral kind of work, because I do wonder people who do prescribe what they feel when they're kind of desperate and need to give people something, because that could be seen as coercion. And certainly I'll be using some of this in our final study, which we're writing up at the moment, on intervening in behavioral concerns, which is a lot about appraisal of other people. So thank you. So can I now ask for people to have questions? So there's a hand here, 3 hands. If you just kind of raise who you're talking, asking questions to, we've got a good 10 minutes.
Hi, Jennifer van den Broeke from the Netherlands. Thank you very much for this very nice bringing together of these 4 presentations. And I really enjoyed listening to the importance of social health. And I was wondering if you could reflect maybe on social health in connection to terms of like inequalities, migration, othering, social exclusion, discrimination, things like that. Thank you.
Myrra, is that something you would like to pick up? Because you touched on a lot of that, didn't you? What is the question? So the question was about how you can broaden or touch on new work related to inequalities, migration, and I know there's a task force of somebody sitting here at the moment.
Yeah. We do have a dedicated task force to it. So we broke down several aspects of social health into specific topics and areas that required attention. And Martina Roos, she is very much involved in that. So we are working on it, and we agree that it's an important topic. But we are just starting up.
So Martina, if you could just stand up for a minute, and on the website there will be the migration task force that will be updated by the new year. What Martina's doing is looking at intersectionality and analysis. If it's quick, we'll hold, because there's a gentleman here next.
I appreciate a separate task force, but to me it seems like part of social health. So I was just wondering if it's, because you show very nice concepts, and I can see it being in there, but I was just wondering if that is something you do take into account or not.
Yes, we do pay attention to it. So this is the basic one, and then we go into a relevant aspect of it.
Do you recall the one session we had when you invited me and I was talking about the combination between social health and intersectionality? Mm-hmm. I don't know if we ever put that presentation on the website, but I think this is what you were asking us, because we were looking at the at one of the frameworks of the social health. For example, we were looking at the domain live and manage your own life, and then we were looking at it through an intersectional lens, and then we were coming up with where we thought there might be gaps. And based on this, we continue to do that in the task force, and I think that is a little bit going in your direction.
We need to stop that
so
one now.
So you can contact me and I can send you the presentation.
There's a gentleman here who's got, and then there was somebody along there, and then somebody at the back. So there's quite a few hands.
Many thanks. I have only comment. My wife Eva and I were fighting against Alzheimer 18 years, and your presentations were very, very important. Many thanks.
Thank you.
Oh, thank you so much. That was really helpful, particularly for us who are trying to improve the area of work. So.
Yes, thank you. I'm Jacqueline Hogenam from the Ministry of Health in the Netherlands, and I'd like to ask a question to Briony, because I really admire what you're doing. I know how difficult it is to find dementia plans and to translate them and know their contents. And I'm afraid I might make your work a bit more difficult. As you said, you were looking for mention of human rights and special actions, but do you take into account that certain dementia plans, like the one in the Netherlands, doesn't mention, for instance, coercion, because it's already covered by law and doesn't need extra attention, as it's already worked on in different settings?
Yeah, so it is something that's actually cropped up before in my own thinking was, okay, maybe they don't have an action on it because it's already been done. But it's a really important point to make, and I'm so glad you brought it up, because I think it is important to know that, really. But yeah, don't worry about making my work more difficult. It's fine, that's what a PhD is, I guess. It's fine, he knows as well. But yeah, it's such an important point to make. And I think while some plans do not specify actions, it is because, like you say, in the Netherlands, it has been worked on. In other cases, that doesn't seem to be the case. So it's, at the moment, I've got to go back through all the plans again, just for my own benefit, so that we know what the situation is within that country to start off with.
Good morning, everyone. My name is Gerald King, and I actually was diagnosed with Alzheimer's at the age of 55. I would just like to say that there is a bit of competition between us young'uns and the older ones, but it's only because, well, in my experience, especially in the UK, there's nothing for people under the age of 65. If you're diagnosed with dementia under the age of 65, you're given your diagnosis, go home, write your will, make preparations, goodbye, and that's it. Whereas if you're over 65, you've got a lot of things on hand to look after you. So that's where probably the competition comes from. Like,
Yeah, no, it's interesting you frame it in terms of competition, and as you say, it's quite different, the profile of services for people of different ages, isn't it? I perhaps should say that the comment that I made derived not from the competition around services, but around attitudes towards and descriptions of, and was for some people with younger people with dementia. And I'm sure this isn't all younger people with dementia, but for some younger people with dementia, we'd heard comments like, well, I'm not that old person sitting in the corner. And it was more...
Although that's down to stigma. Because when you see dementia advertised anywhere, it's an old person sitting in the corner in a high-back chair. And that's all you ever see.
That's the stereotype,
that's got to change. And attitudes won't change until that stigma is...
And it needs to change for the benefit of all people with dementia.
Yes, absolutely. Yeah, definitely.
That's really helpful. And one of the things Georgina brought out was this whole issue of living in the shadow of the fourth age. There's somebody along here that will be wanting to ask a question. Living in the shadow of the fourth age is a curious thing when people look old and other people try and, in an attempt to be nice, help them by actually probably hindering their kind of sense of autonomy. So that shadow of the fourth age and multimorbidity and loss is complicating our work with dementia care, I think.
Hello. I have a very quick question for Briony. So, first of all, a very impressive presentation. It clearly was a lot of work. I'm wondering whether you're also looking into whether these action plans actually lead to action and to what extent they're actually applied.
Yeah, so similar to the question before, it is something that we have thought about. It's really difficult. I was at the National Dementia Plans talk yesterday, and they were talking about, yes, you can say that we're going to action it, but whether they actually do action it is a different matter. It is something that we're going to be looking at to help contextualise our results. Ultimately, from our point of view, it is quite difficult to realise what's actually been actioned. A lot of the plans that we looked at, especially the most recent ones, have action plans for over the next, have action points for over the next 10 years. So we wouldn't be able to tell right now whether they actually will be actioned. But other plans, such as Australia from 2015, we can see that there have been actions that have been implemented. But yeah, again, it's another really important point, so thank you for bringing it up.
So just very quickly, is there anybody from the beginning who had a question that we didn't miss the hand? Because there's nobody online. There is one there, so we've still got a minute, I think, but if people want to hand on now, people will walk out if they don't want to listen anymore.
Thank you. As Chris Roberts said yesterday, I was the eldest person here living with dementia, and I'm certainly not the stereotype. And it's up to us to change the stereotype, and to not be that person, that old person sitting in the corner. You know, I'm 83, and I'm certainly not sitting in any corner.
And to conclude this, I just want to say this: you have literally challenged this whole notion, like the gentleman who started off earlier, of this living in the shadow of the fourth age, because this fourth age is an obstacle. And what you've just done, let alone dementia, is that you said, I'm the oldest person here, and here I am, challenging us, and we need more of that to challenge this image of this fourth age where people have no say in life at all. Ageism, we call it. Thank you.